This season of Beedie on Eyewear, the podcast, is brought to you in partnership with Orbis UK, a vision charity with a mission to create access to eye care around the world so everyone has a chance to thrive. To find out more or to see how you can get involved, visit orbis.org.uk. Enjoy the show, subscribe so you never miss an episode, and let us know what you think in the comments. What led you to paediatrics specifically?
We sometimes use Botox to do that.
They need,
They're amazing.
An Oscar, an Emmy, a Grammy.
Yeah,
they need all the awards.
And always, always, always in little children, vision and amblyopia comes first.
If I'm a parent now, what am I looking out for? Like, how do I know that my kid might be a little bit?
Amblyopia is an eye that is not fully developed.
Mm-hmm. Okay, I want to talk about iPads.
Okay.
Welcome to this episode of Beedie on Eyewear, the podcast for optical professionals and eyewear lovers. I'm your host, Beedie, optometrist, content creator, and spectacle maker. Let's get into today's episode. Welcome to the show.
Thank you for having me.
Thank you for being here. We met in, Orbis last year?
Yes. Yeah.
The World Sight Day brunch.
Yes.
And I remember seeing you buy the French toast. And I remember being like, oh, I'm going to chat to her and asking you to be on the podcast. And I was every time I ask someone to come on here and they say yes, I'm always just like, oh my goodness, like, thank you so much. I'm always so shocked.
Well, we bonded over your dress, I seem to remember.
Oh, that was a great dress.
That was a great dress.
You are an ophthalmologist.
I am.
A paediatric ophthalmologist.
Yes.
And you've done a few things in your career. You have done all the things.
Yeah, I've had a slightly unusual path.
Yes. Talk to us about how you got to be where you are.
Sure. So I obviously did my training in ophthalmology generally in London. And then I came to Moorfields to do my fellowship in paediatrics.
Yes.
And then when I completed my training, I, because of my husband's job, moved overseas. So I actually went and lived in Rwanda for 4 years.
Yes.
And then I worked in the in an NGO actually, but within an eye hospital out there for seeing children in Rwanda for 4 years, which was amazing.
Yeah.
Had 2 of my children when we were there, and then came back and rejoined Moorfields as a consultant.
Like a full circle.
Full circle.
Okay, let's go backwards. So you did ophthalmology, which is a feat on its own.
Yeah.
And then you specialized in pediatric ophthalmology. What led you to pediatrics specifically?
Do you know, again, I had a slightly, I was totally not interested in pediatrics all the way
What
through.
were you interested in?
I wanted to do adnexal, so ocular
Okay,
plastics.
oculoplastic. Okay.
So I was very, very much ocular plastics all the way through. It's a 7-year training, and all the way to the 6th year.
Yeah.
I was plastics, and then something just changed, and I wasn't quite sure.
You just woke up one day, you were like,
I felt like it wasn't, and things had changed in terms of what we were allowed to do on the NHS in plastics.
Okay.
So,
was it more restricted?
There was more restricted, and I
Okay.
just thought, no, do I want to do this forever? And then when I came to Moorfields in my training, I asked to do pediatrics and adnexal plastics to sort of compare them.
Yes.
And ended up choosing pediatrics. Although actually it was, when you do pediatrics and Squint, and the Squint has adults.
Oh, Squint with adults as well. Okay, yeah.
And I was very much adult at that point, didn't want to do the children.
Yeah, because they're so
it's
cute
hard.
And also it's the parents, isn't it?
And I hadn't got my own children then, which I think makes a big difference as well.
Did you find a change from when you had kids? When really?
Well, because you're so used to children when you have your own children.
Yeah.
They're not terrifying creatures.
And they're there all the time, as opposed to here for an hour for an appointment and off you go.
I mean, examining children is hard, and I totally get that, and I totally get why people lack confidence in it, because you sometimes get
scary.
one shot, you get one go.
Yeah, and you have to really be confident in. So, I mean, as an optom, now I don't so much work with kids because I've done cataract clinics and med ret, and those are more like old people diseases, So I feel like I don't really see kids that much, but when I do see them in practice, it's fun. Like, I feel like it brings out your inner child. You know, it's just like you can have fun, you can kind of just be a bit like quirky with it, but also there's pressure because you think to yourself, especially if they're like younger than 7, you're kind of like, hey, I want to make sure, I mean, you always want to make sure you're doing the right thing, but I want to make sure I don't miss something, or I'm not the reason that now that they can't get patching done, or now they're amblyopic, or now, do you know what I mean? Like, you kind of feel a bit like,
No, I think that's universal. I think all of my ophthalmology colleagues who don't routinely see children have the same fear.
Yeah.
And we see it in the optometry community as well. It's a fear of missing something, and missing
or
the
being
opportunity,
wrong.
and a fear of getting it wrong. And mixed in with the fact that sometimes, they are screaming, you are having to hold them down, or they're
and
flying across the room. It is hard. But also, it's incredibly rewarding. And like you say, it's a lot of fun. It is fun to deal with children all day.
Yeah, I would imagine so. I mean, and I guess also being able to calm them or explain things to patients, because you see really young children, like the itty bitty.
Well, so I specialise in paediatric cataract, so I see them from birth. Okay. So cataract, as you know, is picked up at the baby check on day 1 and week 6, so they're really tiny. Yeah, everyone's very emotional. Yeah, the mum has just given birth and suddenly she's got a lot going on. She's in my clinic. Yeah, so we see them very, very young. Most paediatric ophthalmology is in the older age group because most of it is squint and amblyopia, and that's the kind of preschool group. So it's the sort of 2 to 5. But yeah, when they come very, very little, I mean, to be honest, examining a baby is quite easy because they can't.
Because they just sit there. Yeah. They don't really. It's like people say, like when they have kids, like when they're newborns, it's all right because you kind of know where they are. They stay where you put them. It's fine. When they start moving around, now you're like, what was that?
Yeah,
what's
toddlers.
going on here?
Toddlers are hard.
I've heard that the toddlers are.
Sort of 18 months to 3 is the hard bit.
And then
both in terms of parenting them, but also in terms of trying to examine them.
Because they have life, they have motivations, they want to do things.
Yeah, and you can't negotiate. You can negotiate with 3.5, 4. You can give them screen time or chocolate. You can't negotiate with a 1.5-year-old.
I've never considered that part of things.
Yeah, it's true.
When we talk about squint and amblyopia, so there might be people watching this who maybe aren't clinical or are just have a kid and they're like, oh, I clicked on this, let's see what this is about. How do we explain to parents what a squint is, what amblyopia is? What kind of conversation do you have with them?
So amblyopia, amblyopia and squint are very closely connected, as you know. So
and lazy eye, right? Because people everything's conflated,
yeah,
right?
And a lazy eye in layman's terms can mean multiple things. So to us, a lazy eye is amblyopia, which is an eye that doesn't see.
Even though it's healthy.
Even though it's healthy. Sometimes a lazy eye is, in sort of layman's terms, becomes a squint, and that's where it gets a bit confusing.
Yes,
and a squint is an eye that is not pointing in the right direction.
Yeah.
And you can get amblyopia because of a squint, and squints can be made worse by amblyopia. So everything's interconnected, but they are different things. Yeah. So when we get children in clinic, I mean, I will always say to them, in young children, vision comes first. So we think about amblyopia first. And amblyopia is an eye that is not fully developed. Children's vision develops until the age of about 7, from the moment they open their eyes to about 7. And along the way, the eye has to be seeing in order to create the pathway between the eye and the brain. Yeah. If for any reason it's not able to do that, then it doesn't develop properly. And that's when you get amblyopia. And that's why the mainstay of treatment for amblyopia is forcing the child to use the eye by patching. And that's where you cover the good eye to make the bad eye see. Yeah. A squint can happen with or without amblyopia, and that's where the eyes are not pointing in the same direction. They can go in any direction. Yeah. Most common in children would be inwards or outwards, but they can go up and down as well. Yeah. And if you have a constant squint, then that eye isn't seeing because you would have 2 different images going to your brain. So squint can cause amblyopia, but they're not the same thing. And always, always, always in little children, vision and amblyopia comes first because you have a timeline for that. After the age of 7, we stop being able to treat it. Squints can be treated at any age, including into adulthood. Yeah. But it's the vision that comes first. Yeah.
And so we mentioned one of the things that could threaten vision at that early age is a squint, which can lead to amblyopia. What other things can threaten the vision?
So obviously big things such as cataract can, and problems like pathology in the eye, something wrong with the eye. But the most common thing is just uncorrected refractive error. So particularly if they're an ISO, meaning one eye has a stronger prescription than the other. And that is one of the big silent causes of amblyopia that we usually pick up on school screening. And because children will behave completely normally, they'll behave like they can see perfectly well, but one eye doesn't see.
They can with the one.
Yeah, exactly. Yeah. And even when it's both eyes, if both eyes have a high prescription, children will focus through it and behave like a normal sighted child. Yeah. So parents often find that very difficult to understand, why my child who's behaving totally normally needs glasses. But it's because they are really working to focus through it. And if we don't correct it, they will often end up with a squint, particularly if they're hypermetropic long-sighted. So children will act like they are totally fine.
And they are in their mind because they have nothing to compare it to.
Normal for them.
Yeah. And I wanted to ask this later, but actually bring it up in terms of parents, right? So if I'm a parent now, what am I looking out for? Like, how do I know that my kid might be a little bit, something might be off, something might be wrong with their vision? Like, are there certain things that I should look out for? Or not even just parents, guardians, or, friends, whatever, neighbors?
I mean, obviously, any behaviour that suggests the child can't see. So if they're short-sighted, they tend to kind of squeeze their eyes, and all toddlers and young children will always stand close to the television or whatever it is they're looking at. So standing close to what they're looking at is not necessarily a marker of anything.
Okay.
But if they're doing it consistently and they seem to have to do it, then obviously that would be a sign.
Yeah.
The biggest thing really is a family history, and because if they have a squint, you're going to take them anyway.
And stuff and amblyopia, right?
But just glasses. So prescription myopia is strongly genetic. Particularly high hypermetropia is quite familial, not quite so genetic. But so if the family wear glasses, then get them checked. Because it's a really high chance.
And then how soon should you be taking your child to have an eye test? Like, what would you say is?
So if you see them struggling at any age, we can test them at any age. But otherwise, if there's no visible issue, then I would say the year before school.
Okay.
So the sort of 3.5 to 4.5 age group. And most community optoms will be happy to do that age in a cooperative child.
Yes.
If they're not cooperative.
And there's ways. I mean, sometimes people will say, there's a tweet that went viral some time ago, and there's like a video of a little baby, and like a baby. So baby that the glasses are tiny, they've got the band around the head, right? And so they put the glasses on the baby, and the baby's looking around like in awe, like, oh my goodness, faces, right? And then someone quote tweeted it and said, how can they even tell what the baby's prescription is, right? And a lot of people think that. They think, but okay, I take them for an eye test. How can they know? In older kids, we can do pictures. I love doing the pictures because it's so great seeing what kids call things.
Yeah, I know.
And I make them really big, and I just say, let's just get an idea of what this image is to you. So whether it's duck or a quack, whatever.
Chicken.
We call it that, and we just stick with that the whole time. Yeah. So there's that. But when they are really, really, really young, what ways would you use to kind of figure out what the prescription is?
So in terms of their prescription, it's a cycloplegic refraction. So we put the drops in.
Cheeky ret.
And exactly.
How do you ret like a baby, like moving around and that?
You move with them, basically. But it's actually not so difficult. The toddlers are harder, as I say. That the 1.5 to 3.5, they're the really difficult ones. The babies are fine. But in terms of assessing their vision, it's all about behaviour. It's visual behaviour in little ones. And you can do things like cover one eye and see if they scream at you. Because if you cover their good eye, they will hate it.
They'll be fine.
You cover an eye that's not seeing, they don't care. But the orthoptists are real experts in this, and they use kind of
orthoptics. They need.
They're amazing.
An Oscar, an Emmy, a Grammy. They need all the awards.
Yeah,
they are fantastic.
Tell, they can grade it, but it is an estimate at that age because they're not.
Which is better than having nothing. Yeah,
the main thing is, do they have a difference between the two eyes? So it doesn't really matter so much. We're not really looking so much at what the level of vision is. I mean, obviously we are, but what's most important is, do they have a good eye and a bad eye?
Yes, exactly.
Do we need to be looking at that to even it out?
To avoid amblyopia in the future.
Exactly.
Yeah. Because that can really affect people. I think with amblyopia, you kind of see it as like, oh yeah, you got one eye, is a little bit lazy. It's not really seen as that deep. Like, okay, it's always been bad. But when it comes to people getting a bit older, maybe you have cataract surgery, and then if something goes wrong with the good eye, and now it's like, we're left with ambi over here.
Yeah, there's quite a lot of work to suggest that if you have amblyopia, and so a good eye and a bad eye, you have a higher chance of injuring the good eye. Essentially, it seems that they kind of lead with it, and so there is a higher chance of injury to that eye. So always vision comes first, prioritising getting the vision as good as we can. Because we don't know what's going to happen in the future.
Yeah, exactly. Unfortunately, I wish I did. Can we maybe briefly talk about emmetropization?
Okay.
Because I think it's really interesting and that's the process of basically how your prescription should develop as a child. So when you're born, you're slightly hyperopic, right?
You're about +6.
You're like, cool, there you go. Well, there you go. You have a plus in front of your prescription. Yeah. And the idea is that your eye develops because it's tiny, right? And it grows and grows and grows until you should be about emmetropia, so prescription of nothing, by like, what is it, like 6, 7? When
most of your growth happens before the age of about 6, but there is a small amount, and we say it finishes growing at 12.
Okay.
But it's kind of like the biggest shift is in the first year of life. It then slows down, but it's still pretty changeable until you're about 3, and then it slows down again, 3 to 6, and then the small change is 6 to 12.
Okay.
So really, we would say until 12 is the final result.
And ideally, in a normal person or in the average person, you should become emmetropic.
Yeah. I mean, that the process is designed to get you to zero, I suppose. But
so then by the time you're 12, your actual length is normal. It's like that of an average adult.
Yeah. I mean, it's close to that quite early on.
Yeah.
But,
and then you just live the rest of your life with, unless you're like me and you're myopic, in which case, it all went wrong.
Yeah. Well, I mean, this is the thing. We know that it does change a little bit through the teenage years, and we've all met and know people who are myopic from later on. So changes can happen. It's not like it absolutely cuts
set in
off
stone,
at 12.
Yeah, but typically.
But the majority of it is done by then.
This episode is sponsored by M2M Eyewear, a London-based eyewear brand offering made-to-measure frames for opticians. To find out more, visit m2meyewear.com. Back to the show. Okay, I want to talk about iPads.
Okay.
Quickly. Or like iPad kids, iPad generation, all that kind of stuff. Yeah. Because back in my day, we didn't really have iPads as kids. We'd read books, or we'd use a family desktop, or we'd watch TV, right? So we weren't so like here all the time. Or is there enough research to suggest how iPads are impacting the kiddies? Like, is there enough? Do we know enough at this stage?
So the things that we do know are that it's not so much the screen that's the problem, it's the constant near focus.
Okay.
So all the work really derives from the myopia research, but children have a habit. I mean, all of us have a habit. When we're looking at a screen, particularly late at night, it tends to come closer and closer and closer to the face.
I'm the same.
Everyone does it.
I don't need it up here. Why am I doing that?
No, exactly. You don't need it here. You have to really make yourself. So the lesson the message I always give to the parents in my clinic is, get into good habits really now with reading. So we cannot take away the screens and the iPads from these children, because when they get to secondary school, it's all on the screen, all their education, their homework, and then their play as well. So we have to get them into good habits from the beginning, which is holding things at a reading distance, not sort of 10 centimetres from the face, so 30 centimetres or thereabouts, and taking regular breaks from it and mixing it with outdoor activity, because it's not the screen itself that's the problem, it's the constant near focus. I mean, there's all sorts of talk about blue light and affecting sleep and things like that, and yes, that's something to think about as well. But in terms of your vision, you get the same thing with bookworms as you do reading a book, for example, than you do with a screen. It really is a case of getting to good habits about using screens or reading,
because they're not going anywhere. Like at the end of the day, in fact, they're going everywhere,
and they're incredibly useful when we're patching, because children will use an iPad with a patch on. They won't, if you say to them you've got a patch for 2 hours, and they'll scream at you. But if you say you can have your iPad for an hour,
this is the negotiation.
If you wear your patch, they will do it. So they're really useful for patching.
And then does that help the near focus with
because they are engaged in the screen. They really are.
That is so okay with patching, right? Because I don't patch patients. I will send them to someone like you and be like, "Hey, girl, sort this." So, what is
referral?
Short and sweet. So, what is the protocol for patching? I'm sure it changes depending on the person, but in general, like what? So, say I'm referring someone, what can I say to them? Hey, likelihood is they're going to tell you something like this.
So basically, we always use glasses first to correct them, because certainly in the sort of lower level amblyopes and sort of the milder anisometropes in particular, if you give them the glasses to correct them, that might be all they need.
And would you give them full prescription? Depending on the level of anisometropy, because sometimes I'm like, do you give the whole thing? With
anisometropy, the main thing is correcting the difference. If their eyes are straight, you don't have to give them the full prescription if it's a hypermetropic prescription. If there's any suggestion that they're not binocular, they're not straight, then we would give them the full prescription. And if their vision's really poor, certainly in their better eye, we would definitely give them the full prescription. So there's no harm in it. We might tailor it later if they don't need the full prescription. But the main thing is correcting the difference. So correct the difference in the anisometropes, give them the glasses if they're just an ametropic amblyope. And then once they've had chance to get used to the glasses, which takes a good 2, 3, even 4 months sometimes, that's the point at which we would start patching. And the amount of patching we do depends on how bad the vision is and how old the child is.
Yes, okay.
If they're really young, they're very sensitive. You don't need to do too much.
You don't want to reverse it now.
No, and that is possible. But they would, the average really across all of them is about 2 hours.
Okay.
If you're getting towards 7 and the vision is down, then that's when we start to go up and we do 4 hours, sometimes even 5 or 6.
Okay.
But that's quite unusual.
Yeah.
It's usually 2 to 4, depending on how old you are and how bad your vision is.
Yeah.
Whilst doing something visually interesting. And this is where the iPad
come in.
Yeah.
Right. Okay, that makes sense. So then as an optometrist, I see this patient in practice. It makes sense for me to give them the glasses
and
do the referral.
Please
don't just say,
glasses.
oh, I'm chilling, you do everything. Then they can be using, they might get to you and maybe not need patching or not need patching as much.
Exactly. So absolutely, whenever we get these referrals, we now try and call back up and say, please issue the glasses. We will see them
until the appointment,
but please give them the glasses. And I think people are frightened to give the wrong glasses. What if it's not? And actually, it's just give them the glasses. If you want advice, we'll give advice, but really just give them the glasses. Yeah. We will change them if they need to be changed, but give them something. Because actually that is the mainstay of their treatment. And that might be all they need.
And also, we don't know how long it might take for the referral. So in that time, they're just lollygagging with nothing. When actually you could give them something that can help them along the way.
Exactly.
Oh, this is so interesting. Okay. I want to go back to the work that you've done in Rwanda.
Yeah.
Right? Because you've also worked with Orbis. You went on the Flying Eye Hospital,
yes,
which
it was amazing.
Honestly, we're going to talk about that. So this season is in partnership with Orbis UK, and I would love to kind of get more of an insight into your experience so for those who don't know, they have a plane, right?
Yeah.
And inside the plane is a hospital.
So it's a lecture theatre at the front half of the plane.
That's crazy.
And then an operating theatre and recovery at the back half of the plane.
That's crazy.
And the really crazy thing, which I actually didn't know when I went, is that they live stream the surgery into the lecture theatre. So you have a whole series of trainee doctors who are watching you operate, and you're mic'd up. So
you're kind of like narrating what you're doing.
You're either narrating, or because the idea with Orbis is training the doctors in whichever country you're in. So, for example, I had the 2 guys that I was training, and I would be teaching them. So I would be talking to them about what they should be doing.
Yes.
And that's live streamed and mic'd into the lecture theatre, so all the other doctors can listen. And
technology is so
cool.
It
is incredible.
It's so cool. That's
very
amazing.
Cool.
But you're in the plane. So the lecture theatre is like what, first class area, right? Or the cockpit?
The lecture theatre is it is at the front of the plane. What would be
like first class,
left.
Right?
Yeah,
to the left. Exactly. One day I'll know. And then the operating theatre it's
kind of in the middle, and then recovery at the back. Yeah.
Fantastic. So how did you get involved with Orbis in the first place?
They actually contacted me because of my time in Rwanda. So they were going to Rwanda, and they wanted to do paediatrics and strabismus.
Oh wow! Oh my God, this is like perfect alignment.
Yeah, and the guy, the woman, Shiku, who's amazing, who's in Rwanda, who was kind of hosting them and coordinating for them. I used to work with her when I was there. She was my boss. And she said, you must speak to Lucy.
Oh, okay.
So they then approached me. And said, would I be interested in going? And it was amazing to go back. It was wonderful.
How long had it been since you lived there that you went back?
I left in 2018, so 7 years.
Oh wow!
So a long time.
Must have been so nostalgic.
It was amazing because obviously it's changed, but it's still
it's very much the same
place. And a lot of the teams, obviously Shiku was there, and her husband, who's also an ophthalmologist, and then some of the nurses who I'd worked with. So it was really nice to
like
go
a reunion.
Back and see the team. Yeah,
that is. So then the plane. Sorry, back to the plane. The plane flies.
Yeah.
And so did you fly on the plane?
No, so the plane goes ahead.
Okay.
And because it's, it doesn't, you're not operating in flight.
Imagine. It's like an episode of House or something.
The plane flies and lands on the tarmac, and then it's a whole process that the crew set it up as a hospital.
Yes. So people then come to...
And then they fly you in when it's ready, basically.
Yeah. Okay. What was that like for you?
It was really, it's amazing. It is a very cool thing. I mean, it's a novelty, but it's really well set up. And the thing I really loved about it is that it's properly training, and it's not just training the surgeons.
Yeah.
We take out the recovery nurses, the theatre nurses, so they train the local theatre nurses and recovery nurses. They have the biomedical engineers.
Yeah.
They train the local biomedical. So it means that you train everybody in the pathway.
Yes.
Meaning that they can replicate it when we leave.
Yeah, which I think is something I really love about Orbis. I think sometimes like charities do this thing where it's like, oh, everything here is working well because of me, right? So like I'm making things happen and it's great. And that's great. Like everyone, do your thing. But this is really good because it's like that saying where it's like, what is it? Give a man a fish and you feed him for a day. Yeah. Teach a man to fish and then you feed him for life, whatever. Exactly. It's that thing where it's like, okay, actually, we don't need to be here anymore. We've done our job, and then you guys can carry on and like go forth?
So you when in the trip, certainly in Rwanda, I had 2 days on the plane, and then I had 2 days in the local hospital as well.
Okay, this Rwanda International Institute of Ophthalmology.
Yes.
Yeah. Okay.
So, but in the local hospital, so that's the organisation that I used to work for.
Yeah.
And it's hosted in one of the local hospitals, Kibagabaga Hospital.
Okay. Yeah.
And so we would do the teaching on the plane, sorry.
Yeah.
And then go to the local hospital. So you get all of the staff who are at the hospital. And train those as well. So it really was. It was amazing. I mean, I completely loved it. It was great to go back. And
how long were you out there for?
That was a week.
A week. Okay. Yeah. Okay.
And they were there for longer. So normally they're 2 or 3 weeks, these programs, but there's a week of simulation training first.
Okay.
So the doctors get simulator training, which is really an incredible thing to be able to offer.
Yeah.
And then obviously the real patients the next week.
Technology. So then how do they, so I guess the people on the ground will organize the patients and things. And do you get like follow up with the patients? Because if you're there for a week, do you get to see sort of how they're doing?
So Orbis has this incredible platform Cybersite where they can upload, and still they could upload photographs and say, this child's come in, what should I do?
Yeah.
So they did that before. So I could pre-screen the patients that were going to come.
Okay, from wherever you are,
you can see them, and then
this is telemedicine essentially.
And then we met them in person on the first day of the trip, and then obviously they have the surgery, and then 2 weeks later they come back and they upload the results onto Cybersite, so I can see how they did,
how they're doing. Yeah. Oh, that's nice. So then you do have the continuity of and I guess for you, like, it's really full circle because it's Rwanda, you've been there, you live there, and you come back and you're doing the same things, helping people.
In fact, some of the patients we saw on the trip had been my patients when I was there.
Stop it.
So the mothers, remembered me.
Of course. Who could forget? Okay, so say I am watching this and I'm like, oh, this sounds cool. I want to go on a hospital plane. Like, how can you get involved?
So on the Orbis website, there is a link if you're interested that you can click and fill in the form. And then they basically, they match people to trips. So obviously I was a good match for this particular trip.
Yeah.
But yeah, you fill in the form on the Orbis website. And
is it just ophthalmologists that they're looking for, or do they?
So it's anyone to do with the trip. So obviously anaesthetics as well, and then the nurses, the recovery nurses, and anything to do with the ophthalmology sort of surgical.
Yeah, everything involved. Yeah, because so many people are involved in making it happen. Yeah,
this is the thing. It's often about the surgeon, but actually the surgeon can't do what they do without everything.
Without
else.
the team. Oh, absolutely.
So, yeah,
absolutely. Because it's like, oh, give me the thing. Yeah, love that. Okay, so normally I end this by asking people to give a piece of advice to somebody who might be watching this, right? What is one piece of advice that you have for somebody who's watching this?
So it depends on who we're talking about. So for optoms, I think we've already covered it. I would say, please give the child the glasses.
Give them the glasses.
Give them the glasses.
So would you say cyclo them and give them the glasses?
You can't really. I mean, older children, yes, you can do a subjective.
What are we saying by older? What do we mean by older?
So in the hospital, we do 8 and over get subjective, under 8 get cyclo. But if it's a child who doesn't, if it's a routine eye test, no one's got real concerns. A 5-year-old can be done without cyclo.
Yeah.
But anything under that, you need to do a cyclo.
And I guess if the stereo is a bit rubbish, or
if there are concerns of any kind, they've got to be done with a cyclo.
Yeah.
But if they're just walking in because it's like, oh, it's we ought to
I brought their brother.
Test.
I thought might as well have it done too. Yeah.
and they're 6'6", and you're like, that's fine.
Yeah, fine.
But for parents, I mean, I would say, please get the child's eyes tested. Children can hide refractive errors and amblyopia, and by the time it's picked up at school screening, we do have some time to treat it, but it's harder. So if you can get them in a year earlier, it gives us another year when they're more sensitive.
And still plastic in the brain.
Yeah,
and then they
absolutely. So please take children to get their eyes tested.
Love that advice. I give that advice too. So do you want the people to find you? If somebody wants to find you, they've got a kid, they go, oh, I've got a bit of a squint, I want to get that sorted. Oh, maybe we should talk about the squints actually. So the adult squints, how often are we doing adult squint surgery? Because isn't there the risk of like diplopia, like intractable diplopia and stuff like that if they're suppressed? Like what are the parameters with the adults? Like what can we treat?
We can treat anything. So the thing about adult squints is that adults do get double vision. Children don't get double vision.
Yeah.
The intractable diplopia is usually when it's been unmasked by excessive patching, which is why patching does need to be monitored. But with adults who have diplopia, we will find the place where they don't have diplopia. Be that with prisms, we sometimes use Botox to do that. And then you can put them into that place.
You operate to those
with adjustable squint surgery. So you do most of the surgery with them asleep as normal, and then you wake them up, and the last knot is tied on a bow like a shoelace, and you can adjust it. You can move the muscle when they are awake. So if they wake up and say everything's double, then we have the ability. No, you don't go back to sleep.
Oh, wait.
No, you just numb the eye.
Do topical, okay.
And then tighten it or relax it. And you can move the muscle based on what the patient is telling you.
Oh, that's fantastic.
Which is amazing. So adult squints can be treated.
Yeah.
And, it's a funny thing that people think it can't.
Yeah, I feel like I just have that in my head. Like, oh, yeah, soz, babe, you got to live with it now.
No, we get
a little Fresnel on there.
Parents who come in with their child, and you sort of treat the child, but you're looking at the parent
like, babe,
thinking,
you get in my seat right now.
Do you know that we can do something about that? Yeah. And they often don't.
Yeah.
So yeah, adult squints can be treated. Please send them in.
Okay, fantastic. And if they want to send them in, where can they find you?
So I work at Moorfields, which is obviously at Old Street, although it's shortly to be moving to King's Cross. But
is it? So what are they going to do with that green line out the station?
I know. The green line will go.
No way. Oh, end of an era. When's that supposed to happen?
2027.
Oh, I need to go. I need to do one last trip on that
the green
that
line.
Green line.
I know, we'll miss the green line, but we're moving to a purpose-built, really impressive building up in King's Cross.
Oh, brilliant. Okay, so they can find you there.
They can find me there.
Great. Well, that's all. Oh, subscribe. I always have to remind myself to ask people. If you made it this far, thank you very much. Subscribe, watch the show, share it with people. If you have kids, if you want kids, if you are a kid, share. Okay. Thank you so much for being here.
Thank you for having me.
I really appreciate it. How did you find it? You
good.
You had a good time?
Just a chat.
I told you, just a cheeky chat. Oh, thank you so much, Lucy. It's been great.
Oh, lovely.
I can set you free now.
Thank you.
Get out. Good to go. We've got any plans for this?